All right, good morning, and I will try and make sure that we all get to lunch in time. And I'm going to really focus on the importance of understanding disease mechanisms and following patients through time and the lessons that we learn. And I was tasked to speak more on the less represented hepatic glycogen storage diseases. So I'm going to focus on GSD type 3, type 4, type 6, and 9. But the lessons that we are learning from here, I think, are applicable across the board. So my name is Priya Kishnani, and I'm at Duke University Medical Center. And I think that the one important message to give each one of you here is that we continue to learn from our patients, and long-term follow-up in the rare disease space is really critical. And this is to the point of Dr. Patrick Ryan, who was talking about guidelines. And I think what we understood about certain conditions at one point may not be necessarily the whole story as we now see these patients. So I think Dr. Arig already spoke about this, but if I could just focus on this branched structure of glycogen, just a moment, and that's the laser pointer, to just show you that there is a reason why we have this branched structure, because it's a soluble form, it's extremely compact, and then this glycogen, which is present in both liver and muscle, does its respective jobs. Again, as Dr. Arig pointed out, in the liver, it's doing the job of maintaining blood glucose levels, and in the muscle, it's the energy source, especially during times of exercise. And so now, without really going too much into this detailed pathway, once again, there's renaming of many of the glycogen storage diseases, with and without the Roman numerals, with and without the hyphen, as Dr. Dwight brought up. But the point is that we continue to learn more. And the way I think about it is either it's a problem with making glycogen or synthesis, it's a problem with the breakdown of glycogen, which is called glycogenolysis. It's a problem with either the synthesis of glucose from other non-carbohydrate sources, what we call neoglucogenesis, and GSD1A falls there, or what we call in glycolysis, which is more in the terminal steps where you're converting glucose to another energy source, which is called pyruvate. So I'm going to walk us through this and try and bring us back to the very beginning of our understanding. That's histology, looking under the microscope. It's really an aid in diagnosis. And when you look, in particular, as we're talking today about the liver, even in someone with GSD type 3, what you can see is that this is from a liver biopsy, and we've got the circles there and then the presence of glycogen. If you look within that cell, there's also the nuclei. Sometimes those nuclei are more marginated or more to the periphery, telling us that there's buildup of a material. Now, if you look at this liver biopsy from another patient with GSD3, and you do a special stain, this is called the trichrome stain. The point is here it's telling us if there is presence or absence of scar tissue. And here there's green material, which is telling us that there is scar tissue. Now let's move to someone with GSD type 4. You can see that dark pinkish material, that is glycogen, but this is what we call a polyglucosan body. This is an abnormal structure of the glycogen because it's synthesized or made differently. Now when we do trichrome stain, you start seeing presence of scar tissue. Now here's where I think the story starts to unfold. For GSD6 and GSD9, they were often called benign conditions. But if you again look under the microscope, I think you can see that there is really not much difference in histology between someone with GSD3 and 6 in terms of presence or absence of scar tissue. And the same applies for glycogen storage disease type 9. So yes, looking at the biochemistry and looking at liver enzymes, looking at the presence or absence of glucose levels, of blood ketone levels is critical. But whenever there is a possibility for an opportunistic liver biopsy, as we had in the past where it was used for diagnosis, I think going back full circle has taught me a lot of the things which we had overlooked when we were studying these conditions. So when we think about the synthesis or the making of glycogen, we've also now learned that you start out with what's called a core, what's called glycogenin, and this starts a process where the first few glucose molecules are built on glycogenin. So because it's doing it by itself, it's autopilot or autoglycosylation. And when you have this glycogenin core, that's when you start have an elongation with glucose molecules. And for this, you need the particular enzyme glycogen synthase, which is very important in the making of glycogen, but we can come back to it full circle later on. Now is the next step is you need to have that branched structure of glycogen. And so here now what you need is another enzyme and the branch points to allow that tree-like structure of glycogen that we see. And then when all these enzymes are working well together, you have normally formed glycogen. Now, when you have a problem with autoglycosylation, you have GSD type 15, and I know there are some families here. So again, a newly recognized condition, which we did not know much about. When you're missing glycogen synthase, you have glycogen storage disease type 0. And when you're missing the branching enzyme, you have glycogen storage disease type 4. And here, these are all challenges with making glycogen. These also become very important as we think about treatment strategies, because if you can reduce the amount of glycogen burden in some of the storage diseases where there's excessive amount of buildup, maybe this is a therapeutic strategy which we can keep in mind. So now going back to GSD type 4, I've tried and told you what's going on, but here is where natural history studies teaches us a lot. This is a point to be made for other glycogen storage diseases. And so the historical classification that we've had for glycogen storage disease type 4 has been at one extreme, what we call the fatal form. It's neuromuscular, and these babies die very shortly after they are born, and they have significant low muscle tone. At the other extreme, I think Dr. Reed brought this up, is what we call adult polyglucosan body disease. It's all by the same enzyme deficiency, but if you look at genetics literature, we call it GSD4. If you look at neurology literature, they call it APBD, and there's almost like a disconnect that is both caused by the same enzyme deficiency. And then we've got everything in between, where we've called, those patients who present with GSD4 now with liver involvement and that are progressing to liver cirrhosis. And then we ourselves at Duke had described what we were calling at that time a non-progressive GSD type 4. And then there is those who present a little later in life as children with neuromuscular or muscle features of GSD type 4. Now, if we had really continued with this system, we are really calling GSD4 as either having neuromuscular involvement, having liver involvement, or having the adult polyglucosan body disease. And I'm again going to tell you the importance of natural history studies. So we did a novel approach to look at the phenotype variation. Are all these patients with GSD4 really in these discrete buckets as we had put them? And I'm going to come back to this because I want to correct myself. This is what I did as a trainee, and I want to fix the problem before I retire at some point. So let me come back. This was with a wonderful student at Duke, and we looked at the literature. And when you see this, and we say those only with neuromuscular involvement, that's 12% of all these patients with GSD4 in the literature, 17% with liver only, just 2% with heart only. But when you start looking at how many of them have more than one organ system that's involved, you start to see how wrong we are and how many now had the entire spectrum. So heart, muscle, as well as liver. That's about a fourth of our patients. And this is just the tip of the iceberg because we haven't followed these patients through. So now, as we had published years ago, because we had seen a few patients with GSD type 4 with liver involvement, they were on transplant list but never got transplanted. and we learned a story, and we call them non-progressive. How correct were we? So we've now followed one of those patients from that original report. This patient was diagnosed at 18 months, had liver transaminases or liver enzymes which were up. This patient is now 30 years old, and now we're recognizing that this patient could have features of adult polyglucosan body disease. So the other end of the spectrum, with neurogenic bladder and difficulties with gait and other issues going on. Another patient that we followed, again diagnosed with the hepatic non-progressive type. The liver enzyme stabilized by 10 years, so hepatologists said no need for a liver transplant. And now this patient has presented years later with adult polyglucosan body disease, and he succumbed to the disease, and an autopsy was done where he was, and one of his wishes was to continue with learning, and so those tissues were sent to Duke. And what we learned under the microscope, that liver was not normal. You can actually see he had frank liver cirrhosis. So what was being monitored was liver enzymes, which had normalized, but by no means was his liver normal. And then when we looked at his brain, what we saw was that there was widespread buildup of these glycogen bodies, or the polyglucosan bodies, in many parts of the brain. So here we go, you follow a patient through the history. He had almost forgotten that he had this non-progressive GSD4, and now he has ended up with adult polyglucosan body disease. So my key messaging is, for patients, continue to talk with physicians if you see or note something, and always, keep in mind that we are here to listen because we are learning. So now as we reclassify just the liver disease in GSD type 4, we used to call it as the severe progressive, and at one point we used to call it non-progressive. And now I'm rethinking of it as a spectrum of liver disease in continuity. And what we had called non-progressive, now we're calling it attenuated. What we mean is it's progressing more slowly than the severe progressive, but by no means is it a normal liver. I hope I showed you that by showing you under the microscope. So at this point, this is as of last year, we're now actually close to 100 participants. So this is a study, and this is along with Rebecca Koch, who's one of our postdocs at Duke, who we hope to bring in as a faculty member soon. So here you can see we collaborate with physicians from around the world, and we collaborate with different subspecialists because we don't know it all, and working in a multidisciplinary team allows us to learn and continue to add to the field, because then as therapies are being developed, imagine if we were working towards a liver phenotype and a muscle phenotype and a heart phenotype, where actually these patients could be presenting with more than one thing. So this was one message. And then you work on clinical practice guidelines, and this was really with funding support by the Association for GSD. Ever grateful for this, which allows us to continue to learn. So now we go back to the mouse model, and this is where the bench and the bedside needs to talk to each other. So this particular mouse model for GSD4 was actually supposed to be for that other end of the spectrum, which was adult polyglucosan body disease. However, we are now characterizing this more at Duke, and it's not just a model for that extreme. It actually has liver involvement, it has involvement of the heart, it has involvement of the muscle, and also the spleen. So this could be a place where we work as we work towards therapeutic strategies to understand the natural history, and then when you're doing the treatment, you're moving more in the correct target. And so at this point, there are therapeutic interventions in the works. One of them is an example using AAV gene therapy to replace the missing enzyme for GSD4, or editing, because there are certain genetic variants which are more common in GSD4, or taking another step. Remember I told you, if you prevent the synthesis of the glycogen, or if you maintain the balance between the making of glycogen and breakdown of glycogen, so you could use what are called inhibitors of glycogen synthase, which are also being talked about here, or other small molecules or oral treatments which can modify how these patients do. So with this, Once again, my emphasis is on natural history studies, continuing to learn so that we can do better by the patients. Now here comes the other part of the pathway. We talked about making of glycogen, but now let's talk about the breakdown of glycogen. And here once again, now we're looking at this fully formed glycogen molecule. And again, as a reminder, there are linkers here which give it the long chains, which are what we call 1,4 linkers. But then to give it the branch structure, we have what is called a branch point or a 1,6 linker. So now let's think about how glycogen is actually broken down. It's a very interrelated process that occurs, and you need the whole pathway to be working intactly to be able to do this. So the first part is phosphorylase kinase. So this is the enzyme which is deficient in someone who has GSD type 9. And I'm going to come back to this again full circle because this is an enzyme, but there are many genes which are working to make that phosphorylase kinase. Phosphorylase kinase then activates the phosphorylase, which is the enzyme that is missing in patients with GSD type 6. And so once that's activated, then what phosphorylase does is this. It's working on that outer branches of the glycogen right here, and it breaks it down. So now you're left with this structure called limit dextrin. This is what we see in someone with glycogen storage disease type 3. So what you've got here is an abnormally structured glycogen, but the debranching enzyme is actually doing two jobs, and I'm going to try and show you that. One is it's removing those inner branches and moving it to the side, but then you still have that branch point which needs to be removed. That's the other aspect and the other job of debranching enzyme. So whenever we're thinking about therapies, we need to be considering that both these domains of this debranching enzyme are doing the job. And then when you have this long chain, phosphorylase, the enzyme that's deficient in GSD6, completely breaks it down. So once again, understanding these pathways, and by fixing one part of the pathway, we've got to understand what it's doing to the rest of the pathway. So these don't work in isolation. And so this is, again, an important aspect that needs to be considered. So enzyme deficient there is GSD9. Enzyme for phosphorylase, when it's deficient, is GSD6. The enzyme for these two functions for debranching enzyme gives you GSD type 3. So now let's come back to what's common between all of these. Very often, and I think for GSD3 it's less often thought of as benign, but there's often the thinking, you normalize the liver enzymes, you correct the hypoglycemia, and things are looking great. I'm going to try and fix this concept for us so that those patients with GSD3 are more empowered. Those with 6 and 9 are more empowered to further understand. Yes, we've got an intact ability to make glucose from protein, as Dr. Arik pointed out, which is called gluconeogenesis, so making glucose from amino acids or from protein. And the treatment really is we do the high protein diet, we do the uncooked cornstarch, or we can talk about it as glycoside. But if you look under the microscope, that's where I started, there still is scar tissue that occurs. And it's not only in the liver, it can occur in the heart, and it can also occur in the muscle because of that limit dextrin structure. So it's not all doom and gloom because we have made a lot of strides, but I think we've got to continue to work. So once again, these are the advancements in the field now of ways to monitor for the hypoglycemia and taking a multidiscipline approach. But here is when, again, we've made more improvements. We can now do better blood glucose monitoring by using a continuous glucose monitor or using what we now know it as a Dexcom. So you can really find periods of low glucose or periods of high ketone before the glucoses have dropped. And so there are ways to manage our patients better. And trying to optimize this, I think, is great. That's one part. But I think we also have to think about biomarkers. What can we do to try and understand what's going on with that glycogen that's building up in these conditions? So this is, again, that structure of that glycogen. And the gray bars are all the 1,6 linkages. And so in the normal process, this glycogen, as it's in the circulation, is broken down by certain enzymes that are in the body, such as amylase, which is secreted by the pancreas, or other alpha-glucosidase. And so what it does is it breaks it down to smaller sugars, and you end up with these smaller limit dextrins, as they're called. And this one in particular, which is called GLUC4, which has 4 glucose molecules, is something that's excreted and is easily measured in the urine. So this was a lot of good work done by the team, Dr. David Millington and Dr. Sarah Young at Duke. We had built it for Pompe disease, or GSD type 2, but now we see that it's also increased in other liver glycogen storage diseases, because that's the focus of this talk today. And so can it be used to help us understand what is going on? And so let's come back to GSD type 3. I think we've all got the story here, that if you have the enzyme that's deficient in both liver and muscle, it's GSD3A. If you have the deficiency only in the liver, it's GSD3B. And this is a story in itself, a lot of pioneering work which was done by my mentor, Dr. Chen, of why some patients have 3A versus some having 3B. And let's go to the next thing. We had learnings from the curly-coated retriever. Since we are talking of looking under the microscope, this particular canine model of GSD3A, we had the opportunity, because we work with a vet at Duke, we did liver biopsies on these dogs over a period of time. And if I can point out to you, I hope I've pointed this out, when you see all this buildup of material, that's the glycogen. But then when you start staining it with what we call this trichrome stain, you start seeing scar tissue. And what you can see is that over a period of time, these dogs with GSD3A were developing more and more scar tissue in the liver. Were they functioning? Absolutely. Here is where I really want us to have an understanding. So these are the liver enzymes, the ALT, the AST, which also comes from muscle, and this is the GLUC4 that I talked to you about, the glycogen breakdown product. In the early stages of the disease, you can see that these liver enzymes are going up. They are going up, even the GLUC4. This dog model was being monitored, was not being treated with cornstarch or anything, so there was no contribution of the cornstarch to the GLUC4. And now, as you monitor these dogs over time, what I want to point out to you is the liver enzymes are coming down, the GLUC4 is coming down. And so if this was someone who was in clinic and we looked at liver enzymes coming down, what is the message that we give our patients? Things are great. They could be great. It could be that you've done well, there's no scar tissue. That's one good explanation for it. But I think we also have to factor that it could be because there is a silence of this ongoing scar tissue which is going on, and that's why these enzymes are coming down. So what does that mean? That we need to really evaluate differently. And now we can do what's called fibroscanning, elastography, MRI imaging, with and without contrast, to better get a handle on what's going on at this level. And yes, if there are opportunistic liver biopsies or muscle biopsies, it's teaching us more as we can now develop therapies. So this is the pathology. So now we went back to our patients with GSD3 and we started looking at their liver enzymes. It's the same story. These patients had initial increases and then the liver enzymes were coming down. The same with the GLUC4, it's coming down. Is this really the best thing for our patients? So we went back and looked at liver biopsies which had been done on these patients. We didn't go out and do special liver biopsies, but if they had previous liver biopsies, we actually collected this. And what we looked at is we look at different stages of scarring of the tissue. Once again, these lessons can be applied to GSD3 to 6 to 9. They can also be applied to GSD type 4. What we saw is that all the patients had some amount of scar tissue, and this was present from pretty early on. So what is this really telling us? That there is silent damage that's going on. The liver has great capacity to regenerate and to do its job. But if we add insult to injury, there could be issues. So here comes the issues of certain medications, the consumption of alcohol, certain agents that should be avoided in terms of anesthesia, etc. So again, my messaging to you is we've got to look very carefully, as we are today in a very exciting time in the field of development of therapies. Now comes the skeletal muscle and the heart considerations. So very often, the muscle disease for someone with GSD3A, and I'm guilty of it too because that's how we've published on it in the past, we've always said it's more prominent in the 3rd or the 4th decade of life. That is, yes, true. But are we missing something going on in children because we focus so much on the liver features of the disease and management of hypoglycemia, etc.? What about the heart? There could be some heart muscle thickness. It's often asymptomatic, but then sometimes we've had reports in the literature that there have been sudden deaths. And I have been in this unfortunate position of knowing of 3 of my patients with GSD3A who've had sudden deaths, and 2 of them were actually college-going students. Autopsies were done because of where this happened, and I will try and build on the story because this is where hearing your patients, learning, and talking to the coroners. One of them was actually in France, where we had to work with the court there. We got the tissues back to Duke because this was the mother's wish for us to understand and to get closure on what was the cause of death. And again, I'm not doom and gloom. It's all about what we don't know and what we actually know, but we're not asking the right questions. And what can we do so that as we develop therapies, we address these particular areas. So this is for the muscle disease. This is work that we had done through a natural history study. And what we saw, this was in children. Even at a median age of 11 years, children can have some musculoskeletal involvement. So would this have been picked up normally? Absolutely not. If you have a physical therapist who's working and does specialized functional testing, strength testing, endurance testing, having them do what's called a 6-minute walking distance, having them get up from the floor and stand up. How much time does it take? How much is it from a chair to standing up? Those are the kinds of measures where subtle findings can be had. I think these are important because you can help the children with protein or with diet modifications, but also it helps us as we think about endpoints for clinical trials. What about the heart? So this was some work which we had done years ago, looking at cardiac pathology. We work with the pathologist. Right up here, you can see there's a lot of scar tissue. This particular patient had a heart transplant and was generous enough to give us that heart. When you look under the microscope, what you can see here is this is the conduction system of the heart. So the beat to beat that we do, here there was buildup of glycogen. If you have glycogen that's building up in your conduction system, it can make you more prone to a rhythm disturbance. So now if you are in a high-risk situation, you could actually have runs of high heart rate, or in that rare instance, a sudden death. Here is looking at the muscles, the small blood vessels in the heart, and this was the eye opener. This is the opening that the blood is flowing through. All the rest is filled with glycogen. So now think of an athlete with GSD3A running and runs out of blood, going through it because it's a narrowed blood vessel. It can result in death. Again, these are generalizations. It doesn't apply to every patient. But there is where the individualized management approach is really critical for our patients with the glycogen storage diseases. So there are emerging therapies for sure. We've definitely made a lot of progress. There is the mRNA therapy approach from Ultragenyx, but that was only going to target the liver, and that has been halted, unrelated to safety concerns, but that would have addressed the liver aspects of GSD3. What is also being looked at now is gene therapy, and I think you'll hear from Dr. Ronzetti later on. The problem with the GSD3 gene is it's really large, and as I told you, it's got 2 important functions. And so if we try and make it a mini gene, we've got to make sure that those functions are maintained. we've also got to make sure that as we make that mini gene, that the body doesn't look at it as something foreign. It hasn't seen the mini gene before. So there are immune issues in general in the field of AAV gene therapy, but these need to be considered. Could there be other ways, as Dr. Reed brought up, some ways to reduce the making of glycogen so you've got less burden, or other ways to target these programs of GSD type 3. Lots of work is going on, but the thing is, we need to understand the diseases so we know what we are treating, and then are we correcting those challenges in those patients with GSD3. So again, the importance of natural history studies. So in terms of long-term complications of GSD3, in childhood, parents are rightly focusing on the hypoglycemia, but as they become adults, there's more of a focus now on muscle. They forget about the liver, and there could be the silent damage that's going on. There could be cardiac concerns. And then in the very long term, which we hope not to see now, is there is a subset of patients that have gone on to develop liver tumors. Some of them have got heart muscle thickness. And that's the other thing about genetics and these GSDs. Which patient is more involved in a particular organ system is not really known. Even within the same family, with the same genetic changes, when we see two siblings, one could have more involvement of, say, the muscle and less of the liver, or more of the heart and less of the muscle. And so again, that individualized approach and taking things forward. So with that, I'm going to come back to GSD type 9, because I think these are some of the GSDs which I feel are rare and neglected. And we need to learn from the other GSDs, but also learn from these rare GSDs, because I think they can inform the other GSDs. So the first thing is, it's called GSD9, but there are 4 aspects or 4 genes which make this particular enzyme. So if you look here to the right, it's a complex structure. It's what we call a tetramer, and a tetramer means 4. And so it's got 4 parts to it, 4 genes that are helping make this particular enzyme work. And so the nomenclature, some of you may know it as GSD9A2, GSD9-beta, or GSD9C, or gamma-2. We've just gone by the gene titles, and so I'm going to try and tell you how we continue to learn. Once again, very similar to GSD3, there is a ketotic hypoglycemia. They have an initial increase in the liver enzymes, and then those liver enzymes come down. So here is the story of one of our patients with GSD9C or GSD9 gamma-2. I really want to continue to build on this story. These are his liver enzymes. That is his urine GLUC4. And they're initially high, and then over a period of time, they've now entered into the normal range. So typically, I would have said this child is doing well. We've managed him excellently with our metabolic dietitian. He takes cornstarch. He wears his CGM or the Dexcom. He uses a high-protein diet. We've maintained him in range between 170 and 150. We're able to manage him with treatment 4 or 5 times a day. And so when he comes to my clinic, it's great because now his liver enzymes are normal. I've managed his hypoglycemia. He's not making ketones. But if you look now at the level of the liver, so he was seen by hepatology, and these are his liver biopsies over time. And you can see that the amount of scar tissue in his liver has continued to increase. So once again, that theme that as you have more scar tissue in the liver, you have less to give. And that's maybe a reason why the liver enzymes are coming down. The good news for these hepatic GSDs that we have is we're able to maintain the function of the liver. So the ability to make the clotting factors. We don't go very easily into liver failure with these hepatic GSDs. But there is that subtle damage that is ongoing or could be ongoing. So once again, I cannot speak in general that everyone who's got a low level of an ALT or an AST is a problem, but it needs to be taken and factored in, and that 1 + 1 here does not necessarily equal 2 in the sense because we've brought the liver enzymes down and they're not hypoglycemic, that everything is fine with the liver. That is a take-home message I want to give each of you as you go home. So a very good medical student of ours actually scanned the literature and pulled all patients that were in the literature with GSD type 9, broke them down where there was information into the 3 subtypes, which gives you liver disease. And here you can see that even in GSD 9A2, which is considered the X-linked or the more benign form, about half of them had presence of fibrosis or scar tissue. For GSD 9 gamma 2 or C, which we know is the most severe form, almost all of them had presence of scar tissue in different degrees. So now I'm going to tell you, this is how we've worked with physician collaborators around the world. If they did do biopsy on their patient, we've tried to enroll them in studies. And this is again from that study. Let me point this out to you. So irrespective of subtype, you can see with GSD9A2 or alpha-2, with GSD9 beta, and with GSD9C or gamma-2, you can see how much involvement there is of the liver when you look under the microscope. So in terms of this liver disease progression, one of our limitations is we can't really keep going on and biopsying our patients. But on the other hand, there could be animal models or mouse models that teach us. So one of our grad students at Duke actually made this GSD9C or gamma-2 knockout mouse model. And what we were able to show was that by 3 months, they have an increase in the glycogen, they have low blood glucoses, they have an increase in the urine GLUC4, they have a marked increase in the ALT and in the AST. And if you look under the microscope, they've got the presence of glycogen, but also already by 3 months, there's presence of that bluish material, which I told you is by trichrome stain, which is scar tissue. So what happened over a period of time? Again, the same kind of story. Over a period of time, the urine GLUC4 came down, the liver enzymes came down, but look under the microscope. The liver pathology continued to progress. So now we are showing it in yet another model that this does occur. So taking this story forward, we took an AAV gene therapy approach where we can provide the missing enzyme. The beauty for GSD9 is that it's liver disease only. So if you correct or if you target the AAV gene therapy to the liver, there is a potential to correct at that level. And so this was work that has been done by Dr. Gibson now, because she did finish and defend her PhD and is going on to do medical genetics now. She was able to show that you can correct the enzyme deficiency. You can correct at the level of the different enzymes in the pathway, both for making glycogen and breaking down glycogen, because that's important too. You can't just treat in isolation. And also, you can correct the liver cells. But the problem, again, is what Dr. Kobel brought up, is when is the right time to do this gene therapy? Because if you do too young, and if it's liver-directed, then as the liver regenerates or as the liver grows, you're going to lose some of your AV gene therapy. So there should be advances, but the idea is now we have a model, we're getting natural history studies, and this is as of last year. This is for our GSD9 natural history study. We already have 167 participants. This is as of last year with the different subtypes. And we have been able to really better characterize what is going on with these patients. The same applies for GSD6, the same applies for GSD3. We're working really hard to better understand natural history studies. And so now in closing, I'm going to come back to GSD type 6. So this was, remember, you need the GSD9 enzyme to activate the phosphorylase, and so that is GSD6. So all in the same pathway, GSD9, GSD6, and then GSD3, they all work in concert. And I want to think of this in a pathway concept now. What are the features in this condition? Ketotic hypoglycemia, increased in the liver enzymes, and if you look under the microscope, there's presence of fibrosis and scar tissue. So here, the lessons have been learned from the mouse model. This is work done by Young Monkleek, who's here and is part of the SAB. And he characterized this mouse model. What he was able to show is that there is glycogen accumulation, there's hepatomegaly, there is elevations of the liver enzymes, and there is liver damage, and there's increased risk for liver fibrosis. So now we need to further do the details of these enzymes over time to better understand it. But I think the story continues to unfold. And so if we go back now, the method that was used by Sammy Fernandez, who was my medical student, Dr. Sarah Grunert in Germany, did the same study, but now with GSD6. So looked at all the literature on patients with GSD type 6, and what was the emerging theme? The same thing. In the first few years of life, you see increase in the liver size, you see an increase in the triglycerides, you see fasting ketotic hypoglycemia, and that when you did a liver biopsy, this is from the literature again, that there was increased glycogen storage, there was presence of cirrhosis in some patients, there was presence of fibrosis. But now remember, this was at a median age of 2.5 years. Already there is evidence of liver damage in these patients. And now the treatment was similar, high protein diet, etc. And in some of those patients where there was follow-up data available, there was persistence of the liver enlargement. In some of it, it had improved. In some of it, it had normalized. But I question, what does normalize mean? Does it mean that there's more scar tissue? Does it mean there's a resolution of everything? Or does it mean that the normalization of the liver enzymes now is telling us that there's silent fibrosis going on? We don't know that. We've got to study this further. And so in terms of GSD6, this is again in collaboration with physicians from around the world. These are patients who are all 5 years and under. Again, a general theme. This is the presence of scar tissue or fibrosis that you can see. It's present as early as 1.5 years, and it's present even in someone at 5 years. And there is the presence of fat, there is the presence of glycogen, and we have work that's coming out soon where we've blinded our pathologist and given him slides from these patients. I can tell you he was not able to tell us the difference. He failed. It was looking the same under the microscope for 3, 6, and 9. And so our current approaches to GSD management are not enough. We all understand this. We're all ready for the excitement of a new therapy. But what are we correcting? If we don't know what we are correcting, we're not going to do justice, and then clinical trial endpoints will not be met. So there are complications which persist, as we know it today. For 3, 6, and 9, a subset can go on. For the liver parts of it can have fibrosis, cirrhosis. There are reports in the literature of cancer. There are reports of left ventricular hypertrophy or thickening of the heart muscle. But how does it apply at the individual level? I think that needs to be followed closely, and patients need to be monitored in this multidiscipline approach to better understand, better treat, take the necessary precautions. Certain medications should not be used, for instance. And so in summary, I want to close. All of these are multisystemic, especially when I talk about GSD4. These GSD3, 6, and 9, think of it as a basket approach, a bucket. Like, what are we learning from one? We can have lessons to the other, especially for the liver phenotype. And we've got to have treatment approaches for these unmet needs. And it may require a combination approach. For hypertension, for high lipids, we use a combination approach. In the cancer field, we use a combination approach. And I think we've got to think about this as we approach our patients with these hepatic GSDs. And so, again, we're always recruiting for our natural history studies. If you have the time, the ability, feel free to reach out to us. You don't need to come to Duke. It's just getting the records and trying to put this information together so that we can continue to learn on this. And with that, I also want to end by stating I'm one of a really, really big team, and this is just part of that big team. There is an entire set of physicians, collaborators, genetic counselors, specialists from around the world that we have worked with. Because I think in the rare disease space, we've got to learn we cannot be in silos. And so we take a lot of pride in collaborations and acknowledging what we don't know. Because the day we say we know it all, and we've got a treatment, I think that's the day we have failed. And so I want to leave us on that note that we all, as a field of specialists, learn from you. So please continue to tell us. Please be your own physician champion or your own champion for your child or adult as you go to the physicians. And in response to the question of Dr. Ryan, guidelines may appear that they are not fully there, but there is information there that's information. Look at places like gene reviews, which are constantly updated. Use those pieces of information because physicians are busy if it's not their specialty, but you can continue with that. So thank you very much.
Can you please put your slide back that shows contact information from our...
Yes.
Thank you.
Does anybody have any questions?
This is a great talk. Thank you. For the patients with GSD3, what's your thoughts? Should they be, as far as with their arrhythmias, stress testing for them, just as routine? I was briefly reviewing the guidelines there, and it kind of, if they have symptoms, but is that something that's considered doing stress testing for those patients who are not symptomatic?
No, I don't think that stress testing is really needed. But once again, an EKG, looking at certain intervals, something what's called the QTC interval. That interval, if it's prolonged, tells us that the patient could be at risk. So for instance, for certain situations, patients are put on what's called a beta blocker. A beta blocker can mask hypoglycemia symptoms, but also may be detrimental in some of these cardiac situations. So knowing and having the knowledge at that individual level is important. I always tell our patients, if you have a sudden increased awareness of your heart rate, or if you're having these skipped beats, etc., please let your parents know. Certain exercises brings it on. Please don't continue to go through it. But on the other hand, we don't want to limit what a child can do. So getting a cardiologist involved and just following through, I think, is where my messaging is on this.
And then with the 7-year-old that you presented, doing the biopsy, the child had a biopsy, I think, at 2 and 3. What was the push to do it at age 7 with the AST, ALTs looking normal? Was it further imaging that kind of prompted that, or was it just strong recommendation?
No. So let me tell you that age 2 and 3 was at that time, it was a diagnostic biopsy. For this particular patient, the age 2 biopsy was done, but enzymology was not possible. The sample was not handled well. So this was a patient where I got this information. It was at another institution, but I took the trouble to find those histology slides. Why was it done at age 7? It's because there was evidence on fibroscanning and also on an ultrasound that there were areas of cirrhosis. So this child was undergoing anesthesia for other purposes, and so the family agreed to get that liver biopsy.
Thank you.
Any other questions?
How does being put under for procedures affect GSD? You just touched it a speck. Should you prevent?
So certain aspects, right? When you are taking someone for anesthesia, maintaining the blood glucoses, which I think we all know. So preparing them well, but making sure that they're in good control before you put them under anesthesia. And then the post-operative aspects of it, making sure that they're maintaining glucose until they're able to eat again. That's one aspect. The second is for those who have a muscle GSD, there are certain anesthetics that we try and avoid because they could be more damaging or more harmful. And so once again, the team approach where they speak to the metabolic geneticist or the endocrinologist or whoever's taking care of that particular patient in preparing for that procedure. That's what I meant by it. I think there's a question there at the back.
Hi. First, thanks again for your whole entire team dedicating so much research to such a rare disease. My question was, you kind of mentioned the emerging therapies for type 3. I've read several of the papers that Duke has published, and seems like there's different approaches. There's the dual AAV. There's various papers that seems like over the years have potential therapies. And you kind of mentioned for type 369, there's emerging therapies upcoming. Like, what is kind of the update on those kind of aspects?
Absolutely, and I think Dr. Arik touched on them. So in terms of those conditions which is just impacting the liver, right? I think those are lower hanging fruits because your target is the liver. But for conditions which are multisystemic, like GSD3, the mRNA approach, say for instance, that was being approached by Ultragenics would only correct the liver aspects, not the muscle or the heart, correct? If you did AAV gene therapy, it needs to be both or all three, liver, heart, and muscle. And yet we've not yet touched on another aspect of neuromuscular involvement, right? We haven't really even scratched the surface there for, say, someone with GSD3A. How much do we know about that? Do we want something that can target that as well? And the approaches could be stepwise because you may not be able to address everything,
Right.
but the approach could be what we know today, can we address those and then build upon those? And so I think you're speaking this afternoon, or is it tomorrow, on a GSD3A gene therapy approach. But I think that's a liver detargeted approach. So that would be tackling muscle and heart because the liver could be handled by diet or by a liver transplant or something else. So we're not there yet with GSD3, and that's my honest statement to you. But things are in the works for it.
Okay. And just one really quick question. I saw that you had mentioned MCT oil on there. Has there been any kind of documented approach? I know it's kind of been like, oh, it may help, it may have benefits. Is that something that GSD3 patients should look into?
Definitely, and you could speak with our metabolic dietitians here in the audience. We do use MCT oil as another fuel source, and I think as Dr. Reek talked about it, is triheptanoin is another, but that's an expensive choice. You could start with MCT and see if it works for your patient, for a patient with GSD3. Okay. Absolutely.
All right, thank you.
Is there a question in the back? Okay.
Is it common for elevated cholesterol levels in GSD patients?
Yes, there can be elevated cholesterol, and I think there also needs to be an understanding of the LDL to HDL ratios. Those are altered, and so when you're monitoring a patient, I think that also needs to be taken into account. The levels are not as high as you see in GSD type 1, and then again with metabolic control, they can come down, but I've often still seen the ratios of LDL to HDL are still not corrected. So that to me is again a very good question that you asked because it could be used when there's a therapy in the works.
Hi, our daughter has type 3A, and we do a yearly liver ultrasound and a FibroScan to look for liver damage. Is there any other testing that you would recommend other than those two measures to just keep an eye on, the liver itself, separate from labs?
Yeah, so that's a very good question. And liver ultrasound gives a lot of good information. As does fibroscanning, but also what has to be, needs to be understood that fibroscanning tells you two extremes, right? If there is a slower progression, and we have actually some work on that I'm going to try and share at another moment, is fibroscanning may not tell you if you go from stage 1 to stage 2, but I think it tells you if you're going from, say, stage 2 to stage 4, So there is that missing bucket of what's going on. But when you look at the child as a whole, one can see it. but then looking at echogenicity in the liver, like, trying to tell the radiologist to focus on those regions. And then if your child is at some point, and I know she's a teenager now, I would also say sometimes alternating with an MRI, with and without contrast, because you get different pieces of information from different imaging technologies and platforms. And so trying to use those as a way to also evaluate would be helpful.
Hi. As you know, I have glycogen storage disease 15, and I'm listening to all this, and there's so many, now that I'm getting older, I seem to have pancreas, fatty things on my pancreas and cysts and ovaries. And I thought it was all neuromuscular, but I'm just wondering what on a yearly basis or 6-month, what should I have tested on a regular basis so that I'm seeing things early enough?
So,
I have heart arrhythmia. I'm like, oh my God, I have that.
Yeah, so GSD 15, and thank you, first of all, for teaching us as much as you did. And because of individuals like yourself, we've got a young person now completely in the field and working on a model for it to better understand it. So having said that to you, there are things that could be part of GSD and there are things that are just part of being an individual. And so talking to your primary care for some of those aspects, but bringing up these things when you go to see your specialist is important. But I think what we are uncovering with GSD 15 is that there is something that's called the cardiac phenotype, and then there's something which is called the muscle phenotype. But what we've also uncovered is that there are some patients who can have a ketotic hypoglycemia, but we're trying to figure that out some more. So once again, the multisystemic nature of these conditions are learned because of patients like yourself. So thank you for that.
Oh, go ahead.
You guys for some fibrosis, other types of imaging like PET scanning or anything like that? Is there anything that you can do to, because it's hard because on some of these where they're normal,
Yeah.
and you can't do liver biopsies.
Yeah. So we actually were trying to develop a scoring system, and that was one of our bright medical students who took it on as her thesis. And that is coming out. And there are some lessons that we can learn from NASH, from non-alcoholic steatohepatic disease. So from the common conditions where you could use blood markers and come up with a scoring system. And I will be glad to share that paper with you. It's under review. So simpler things that we could do, but we're just not monitoring patients over time. So what she did was she looked at those blood markers, and then she looked at those patients who had imaging, and then she looked at those patients who had a biopsy and tried to connect the dots there. And I think we have some good information, which I'll be happy to share. And this is specifically for GSD type 3 that this work has been done.
Thank you. First of all, thank you for a great talk. Learned a lot. But my question to you is, if someone has GSD that affects the heart and has a transplant, does the GSD have the capability of affecting that heart transplant, the new heart?
So that's a good question. That if it is, let me try and address it in a way that's fair. If you have, say for instance, a GSD which affects, say, the liver, the heart, and the muscle, and you did a heart transplant, it would correct the issues in the heart. It would not address the issues in the liver or the muscle. But if you had a GSD which only impacted the heart and you did a heart transplant, that would be helpful. Am I answering your question?
Yes. Yes, you are.
I know it's lunchtime, I'll make this real quick. Again, thank you for the great information. So my number one question is, what is the possibility of a wrong diagnosis in terms of type? And number two, for GSD type 9 or maybe any other GSD, you did talk about some tests that indicated that there is a scar tissue going on, but a decline in the enzymes coming back to normal. My question around that is there a threshold that you would say at this particular point the scar tissue is big enough and we need to address that? Or is there a particular thing that should be monitored around the scar issue development?
Yeah, that's a very, very good question. And my point was that there could be this silent progression and the normalization of the liver enzymes. If you read, the more common situations like NASH or where you have an increase in scar tissue and the liver enzymes are coming down. Now, in certain conditions and in certain genetic conditions, as the liver enzymes are coming down, the functioning capabilities of the liver also becomes less. So, for instance, in those, your ability to make protein or albumin, your ability to make clotting factors, also gets diminished. Fortunately, what we've seen in many of our GSDs is that there's sufficient compensation so that synthetic function or the ability to make is retained. But monitoring those, I think, is an important part of it. And then using technologies, to look for evidence of the scarring, non-invasively, of course, like the fibroscanning, et cetera, is also important. Is there a threshold point? Yes. If you start seeing synthetic function coming down, or if you start seeing that, under the imaging, if you're seeing areas of frank cirrhosis or nodules, I think that is concerning, and there should be involvement of a hepatologist at that point, to help making treatment decisions, because in certain situations, it may warrant a liver transplant.
Thank you. One last question, if you allow me, please. You also did talk about possibilities of type 9 being treated with the AAV gene therapy. Does that mean that it could be truly cured, or is this treatment just for the management of it?
So, a great question. I would say because GSD9 impacts the liver, if you're able to correct the enzyme deficiency, whether it's through genome editing, base editing, gene therapy, mRNA therapy, the idea is, because your target is the liver where the disease is, I think the chance of a good outcome is great. The limitations, which we have, say, for other GSDs, which have other systemic involvement, is you're only correcting the liver and not the others. So I would never say at this point today it's a cure, but it's a good solution and hopefully can help these patients in the long term.
Yeah. Thank you very much.
Priya, I just have one follow-up to that with the 9C.
Yes.
Over here.
Yes.
And you were saying that the age would matter when you introduce that. Are you going to base that on the mouse model that you're studying? The age recommendation?
I think the age recommendation for liver-directed gene therapy is when the liver is not actively, if you're doing AV replacement, right? So I think when we talk to hepatologists, they say either age 8 or age 12, so where the liver is kind of stable. Because if it's AV gene replacement, as Dr. Kobal pointed out, that's episomal, right? And so you don't want to do it in actively regenerating liver, but also you've got to phase it at a point where there's not so much liver damage, where there's a potential for toxicity.
Thank you.
Thank you.